Study of single incision and conventional laparoscopic adjustable gastric band patients in a single U.S. center with 1-year follow-up. Dr. GERO.
I would like to thank the chairmen and the SAGES for allowing us to present our finding on the single incision gastric banding. I'm Daniel GERO, surgical resident in Monte, Switzerland. This is a Brown University study. Authors have nothing to disclose. Single incision surgery has gained a lot of attention in the past years to perform uniquadrant procedures. Gastric banding is an ideal application for such an approach, as all the procedure takes place in one quadrant. Potential benefits of a single incision approach are low level of abdominal trauma, decreased incision-related complication rates, and more satisfactory cosmetic outcome. Many authors have described that single incision gastric banding or single incision laparoscopy is safe and feasible, provides a lower level of postoperative pain and analgesic demand. In our hypothesis, we presume that single incision gastric banding provides similar band orientation on the stomach and identical bariatric outcome compared to conventional multi-site laparoscopic gastric banding. When starting single incision gastric banding, we wanted to be sure that we are doing the same operation. We place the band in a similar position, and we are getting the same outcome. Our first 10 single incision gastric banding patients were matched with 1:2 matching ratio to 20 conventional gastric banding patients from a database of 151 consecutive patients of a single surgeon in a single hospital. The match was obtained retrospectively according to age, gender, BMI, and at least one overlapping comorbidity. The data collection was prospective and took place in the medical office of the attending surgeon. We used generalized linear mixed models for statistical analysis. As of now, single incision gastric banding technique is not standardized. The location of the incision may vary according to the instruments used and surgeon's preferences. In this study, patient had a 5 centimeter incision in the left upper quadrant, where a 15 millimeter trocar was introduced, and 2 to 3 other 5 millimeter trocars were placed adjacent to it. The Nat Hansen liver retractor was introduced from a stab incision in the right upper or indexiphoid area, and the rest of the operation was performed identically to the conventional laparoscopic gastric banding. We used traditional laparoscopic instruments, and the band was fixed with intracorporeal hension suture to the stomach. Here is our study population. We had 10 single incision and 20 conventional gastric band patients. The match was obtained in a fashion that there were no significant differences in sex, age, BMI, weight, axis weight. Operative time was similar in both groups, as well as hospital stay. We measured the position of the band at postoperative day 1 and 6 weeks after with an upper GI study. The phi angle describes the angle between the spinal column and the long axis of the band. And what did we find? There were no significant differences in this angle between cases and controls, and we have noticed a gentle decrease of the angle over time. We presented our findings on the potential role of the phi angle and bariatric outcome earlier this year. So, looking at this table, we can say that the band was in the similar position in 2 groups. The percentage of axis weightless achievement was comparable between single incision conventional patients, blue line single incision, darker line conventional patients. The tendency of body mass index decrease was similar also during that 12 months follow-up. The rate of comorbidity resolution did not show significant differences. Complication rates were kept in the same similar range. There were no reoperations, no mortality. However, one single incision patient had to have an additional trocar for better visualization. We are aware of the limitations of this study. I would like to emphasize the low sample size, and there are some other factors listed on this slide which might have introduced the bias. Coming to conclusions, Results confirmed our hypothesis. Based on our initial experience, single incision gastric banding appears to be a similar procedure to conventional multiport gastric banding in terms of the position of the band on the stomach, weight loss, comorbidity resolution rate, and complication rate. Also, I would like to put in the conclusion that phi angle is a useful tool to evaluate the orientation of the band on the stomach, as we did in the study. However, in the future, prospective randomized trial would be certainly important to clarify these findings. Thank you for your attention.
We'll let you have a sip of water and I'll ask you some questions. Was there a separate, just to clarify, was there a separate stab incision for the liver retractor?
Yes, we use the needlescopic 3mm incision
Okay.
for the liver retractor.
Just to clarify whether it's single incision plus one, there's a lot of differences in nomenclature nowadays, and I'm just wondering, what we're trying to achieve with that. So secondly, the phi angle, how would your approach differ if the patient was found to have an intraoperative hiatal hernia?
Patients who were offered the single incision approach were screened for hiatal hernia, and large hiatal hernia patients were excluded. And in this study, among the 10 single incision patients, one had a hiatal hernia repair during the operation, and this patient was matched to 2 other conventional patients who also had a hiatal hernia repair.
So I'm relieved that in the 2 single incision band studies we saw today, there was not any great significant difference between the 2. So what do you tell your patients about why you're going to do single incision versus multiport? It doesn't look like there's any significant benefit or detriment to doing single incision. And I think in the previous study, there was no difference in pain or outcomes. The only difference was cosmetic, or for the most part was cosmetic. So I guess I'm struggling with why we're doing single incision when we have such a good operation done through several small ports.
Patients are offered both interventions, and depends on patient's choice. We don't push this operation, we'll let them decide. And the main difference is just cosmetic, yes.
Sorry, Dr. Ali Fardoun from UAE, Emirates International Hospital. With gastric banding, single port, we have started in 2009 in Tawam Hospital, John Hopkins. And really it was, and also we have started the sleeve gastrectomy single port at that time. But with the band, we found that if you will go through the umbilical, I didn't understand if you went through a single port through the umbilicus, or it is the incision you were making, you did a little bit up. If you did the incision upper, it is really difficult access, and really the angulation is better. But through the umbilicus, the angulation very difficult for the band. I don't know what's your experience in this. Thank you.
Thank you for your question. We find it easier to have a better view on the left upper quadrant from a left upper quadrant incision, providing that through the same incision we don't put the trocars one next to the other, but we try to separate them the most possible to make a triangulation. And to precise for first part of your question, so we use a single incision in the left upper quadrant where the trocars were placed, and the net hands-on liver retractor was placed from another stab incision in the xaphoid area. So if you prefer, we can call this procedure a modified single incision gastric banding.
Yes, but in this aspect, you are only saving 2 5mm scope, 2 trocars, and doesn't worth, I think, too much in the band to do single port. If you can do it in the normal way, you will little bit of incision, and also you will not have this trauma for the fascia to introduce the single port. Also, it's painful, and it has its own complications, and you are not very comfortable to put the band. While in the single port sleeve gastrectomy, yes, I agree that it is a nice procedure, cosmetic, and it is much better. Thanks.
Thank you.
Thank you very much.